Good afternoon. Great to be here for the third time. My PhD topic is still focusing on comparing the different approaches in total knee arthroplasty. I am Bence Stubnya from the Department of Orthopedics at Semmelweis University. My supervisor is Dr. Zoltán Bejek, and my SMS is Szilárd Vancsa, and the statistician who's helping me a lot is Gergely Agócs. I'd like to thank them for the extra amount of help. Well, our specific goals focusing on comparing the efficacy and the effectivity of different approaches in total knee replacement therapies. Therefore, we have three ongoing projects. The first is a systematic analysis of the literature. The second is a clinical trial, and the third one is to build a total knee registry. Let's see our first project, which is a systematic review and the network meta-analysis. Where we are now is we have the title, which is Subvastus Approach Supporting Fast-Track Total Knee Arthroplasty is Medial Peripatellar Approach the Best. I wrote the article almost, and we are waiting for the internal review. The background of our interest is that the international literature estimating the growing of the total knee, the needed total knee arthroplasty is around 500% in 20 years, and there is still no consensus about the more effective surgical approach. So our clinical question was, does subvastus approach could offer a more effective rehabilitation compared to other approaches? And after our systematic search, we found 34 articles, which was good enough to involve in our meta-analysis. The first and one of the most important outcome is range of motion, which is really important in the early stage of rehabilitation and doing the physiotherapy and the mobilization. Here I'm showing you a very complex, a very big forest plot. By the rows you can see the days, and in the sub-rows you can see the different approaches. The column in the middle means the standard medial peripatellar approach. The little boxes which are on the right side means that the approach offers better range of motion in the given days. What we see is that in the first 5-6 weeks, different approaches, especially subvastus and mini subvastus approach, could offer better range of motion values. Which why is it good? Because the patient could start their rehabilitation earlier and could have better results during the physiotherapy. The other important parameter is the pain measured using visual analog scale. The complex forest plot is the same. So I'm sorry for it that the numbers are a little bit mixed up. It's because the Google Drive, but it doesn't affect the results we got. That we saw in the first 2 or 3 weeks, the so-called quadriceps sparing approaches could offer lower pain values in the first days and weeks, which could offer better and effective rehabilitation as well. The third outcome parameter was the Knee Society score, which is a really complex score system containing one of the same parameters as mentioned by Vicky, and what we saw is the same, that in the first weeks the quadriceps sparing approaches could offer better health parameters and better rehabilitation. So the strength of our study was that we strictly followed the well-defined study protocol. But we have also some limitations as well. One of the most important is our network matrix is a little bit poor because most of the articles compared the different quadriceps sparing approaches to the medial parapateral approach, which is the widely used approach around the world. But what we could say after seeing the results that the subvastus and mini-subvastus approach is supporting fast-track total knee arthroplasty and the quadriceps sparing approaches are superior to the standard approaches. Let's see our second project, which is an observational clinical trial where we investigated the subvastus approach and the medial parapateral approach at the Department of Orthopedics at Semmelweis University. We got the statistical results, and we almost finished the article as well. The background is the same, the question was the same, and the eligibility criteria which are shown here is was very practical. X-ray diagnosed osteoarthritis, conservatively untreatable pain, and the BMI under 40. And the results are very similar to the meta-analysis results, which means that we tried our best. So the range of motion values in our study was investigated in the first 6 days, and we see that the patient operated by subvastus approach could reach higher range of motion values in the first days, and the difference between the two groups are decreasing day by day. We used a painkiller medication protocol, which was a 5-level protocol. 0 means that there wasn't any need for a painkiller. The first level was NSAIDs, the second was paracetamol, and so the second was methimazole, and the third was paracetamol. We divided the patients into subgroups based on the used medication, and after we examined the pain, and we saw the same, that in the patients in the subvastus group could start their rehabilitation with lower pain values. We did the same calculation during activity, and we found the same as well. And after we examined the use of painkillers in the two investigated groups, we found that in the subvastus group, in average, they need around 0.5 level lower painkiller medication protocol level. So the conclusion of our clinical trial is that subvastus approach is superior to the medial parapateral approach regarding to range of motion, pain, and painkillers needed in the early postoperative period. And the third project is to build a total knee arthroplasty registry, where we start our work analyzing the joint replacement therapies in the last 10 years in Hungary, and we found that the registry is well needed in Hungary because the numbers of the total knee arthroplasties are extremely growing. In the last 10 years, the yearly numbers of the total knee arthroplasties grow 3 times. So, and you can see in 2020, the last column, the effect of the COVID pandemic, where the elective operations were stopped. So here we are. We have 2 articles right before the internal improvement process, and the registry is well based on. So thank you for your attention.
So in your registries, that whom could you involve? This is only Semmelweis? I mean, the registries, or this is going to be nationwide?
The plan is that the Doctoral registry could focusing on the Central European region, Central East, Central European region.
What do you mean? So do you actually, I mean, collecting partners for this? And if so, then at what stage you are at?
At the clinics, we have good relationships with the international orthopedic associations.
Because I assume that if you do the registries, I mean, you have a kind of number of parameters what everybody has to measure, because otherwise...
Yes, of course, yes. Yeah. But I thought it's not necessary to talk about it because I have better results and more to talk about the other two ongoing projects.
All right. The other question is that how do you, I'm just curious, I don't know at all, that when you say that the need of painkillers is decreased, that how do you measure this, the need of painkillers?
Well, we stated a medication protocol, and it based on the patient's need. So we follow the Salus agro, the supramalleus sesto. So in our mind was the patient has to be without pain. So we give them a higher medication protocol levels. They have had some need to the medication. And after we collected the data, we did a statistical analysis that is there any association between the range of motion, the level of pain, and the needed medication killer, and all the three parameters were strongly connected.
First of all, congratulations for your actual done a trial. And my question would be that regarding your second project, yes, in which you are comparing two surgical approaches for a medical condition, that were you able to compare the baseline characteristics of the two cohorts? I know that it was an observational trial, but considering confounding factors which can have an impact on pain, like diabetes, peripheral neuropathies, or different other medical conditions, did you consider these during your analysis?
Yes, I just showed you the most important inclusion criteria. We have a wider range of the inclusion process, and the observational trial was because we didn't make the protocols to be a randomized trial. And the problem was that the patient randomization wasn't as good as the definition waiting for it.
Thank you.